I'm going to start just brief outline with hypoglycemia definition and symptoms, counter-regulatory response to hypoglycemia, and then speak about spontaneous versus iatrogenic hypoglycemia in CF patients, and then finish up with treatment and prevention of hypoglycemia, as well as unanswered questions and future directions. So the definition of hypoglycemia is an abnormally low plasma glucose. And I don't know if you all find that as vague as I do, but that's how it's defined. And it puts a patient at risk for injury and death. So in CF patients without diabetes who are not on glucose-lowering therapy, in order to have hypoglycemia, they need to have Whipple's triad, which means they have to have symptoms of hypoglycemia, a low plasma glucose measured at the time of the symptoms, and then relief of the symptoms when the glucose level is raised. For patients that have diabetes, the International Hypoglycemia Study Group came up with classifications for levels of hypoglycemia that the American Diabetes Association also recognizes. Level 1 is a glucose less than 70, but above 54. Level 2 is a glucose level under 54, and then level 3, no matter what the glucose level is, if there's a severe event that's characterized by altered mental status or needing assistance for recovery. So a glucose level of less than 70 is an alert level for patients that are on glucose-lowering therapy, but it's likely not clinically significant by itself in other patients. And symptoms of hypoglycemia can be subcategorized into neurogenic versus neuroglycopenic. With the neurogenic symptoms, that happens when the glucose level is below a threshold of about 58, and that's like the shakiness, palpitations, tremors. The neuroglycopenic occurs with a glucose level under 51, and that has more to do with seizures, coma, confusion. And then when there's severe and prolonged hypoglycemia, that can cause cardiac arrhythmia or brain death. So that's why we take it very seriously. So in individuals without diabetes, when the glucose level goes under 80, then the insulin levels start to be suppressed. As the glucose level drops further below 68, then you have an increase in glucagon and epinephrine. The glucagon role is primary and the epinephrine is secondary. And then growth hormone and cortisol, those start to be released a little bit lower, growth hormone at 67 and cortisol at 55. But those likely do not play a critical role in recovery from hypoglycemia, and the effects occur over several hours. In patients with type 1 and advanced type 2 diabetes, sorry, this is really sensitive every time I push it. So we know that in their case with beta cell failure, they have impaired glucagon response to hypoglycemia, and this then prevents a normal paracrine interaction between the alpha and beta cells. When they have recurrent hypoglycemia, then they have a lower glucose threshold for catecholamine release, and then neuroglycopenia may occur prior to the catecholamine response, and then this leads to an attenuated sympathoadrenal response, and this puts them at risk for future episodes of severe hypoglycemia. In CF, Tony Moran published a paper in 1991 that showed that patients have diminished hypoglycemia-induced glucagon response with exocrine pancreatic insufficiency. However, the CF subjects with pancreatic insufficiency showed normal recovery from hypoglycemia, but the mechanism has not been well understood. More recently, Aitken published a paper that showed impaired counter-regulatory response and incretin response to hypoglycemia in CF patients. So you can see here that there wasn't any difference in any of the counter-regulatory hormones except with adrenaline. But even then, it happened later at 165 and 180 minutes. And this was on an extended 3-hour OGTT. And it only increased by about 66% at 165 minutes, and 61% at 180 minutes in the hypoglycemia group. There was also no difference in GLP-1 or GIP response. Oh my goodness, I barely pushed it. Okay, so with spontaneous hypoglycemia in CF patients, there's a very wide range of prevalence that's reported in studies, anywhere from 7 to 69% on OGTT and CGM studies. Looking through the literature, I really didn't find studies on self-monitoring blood glucose. And in CGM, the rates of hypoglycemia in CF patients range anywhere from 13.6 to 69%. These studies show that CGM may be the most sensitive method for detecting spontaneous hypoglycemia in CF, as well as determining when it occurs and what the triggers are. However, there are limitations of these studies, and it's difficult to look at all of them together and draw conclusions when there's no consistent unifying definition for hypoglycemia. And the definition will vary based on whether it's by OGTT or CGM. So, and the study designs are also variable. There's a couple recent studies by Christine Chan et al., and those showed that there was no difference in the minimum sensor glucose or percent glucose time less than 70 in CF subjects versus healthy controls. However, when CF subjects were grouped together, there was a difference in the glucose percent time less than 60. It was 1% in the CF patients versus 0.2% in the healthy controls aged 6 to 25 years. In a separate study, when the CF subjects were stratified into normal glycemia, abnormal glycemia, and CFRD, then there was no difference in the percent glucose time less than 60. And the authors postulated that perhaps the acute drop in the glucose level rather than the absolute glucose level is what triggers the hypoglycemia symptoms. However, you could make the argument that there was sample dilution because the groups were smaller when they were subdivided into the CF glycemia status. With spontaneous fasting hypoglycemia overall, the prevalence has been reported as a 5.5 to 13% in OGTT studies, and the pathophysiology is related to malnutrition, prolonged fasting, and increased energy expenditure. So when patients have exacerbations and illnesses, then that further increases our risk of hypoglycemia. Other risk factors include female sex and low body weight. And this is important because in CF patients, it's been associated with worse lung function, higher hospitalization rates, as well as worse clinical status. Switching to spontaneous postprandial or reactive hypoglycemia in CF patients, the prevalence has ranged from 6 to 15% on 2-hour OGTT. And when the OGTT is extended to 3 hours, between 45 to 79%. And recently there was a mixed meal tolerance test with incidence or prevalence of 26% on that. The pathophysiology is related to a decrease in the first phase insulin release in response to glucose load, followed by a delayed inappropriate amount of second phase insulin secretion. So some studies reported higher insulin levels at that point, but others did not report a difference, but that it was inappropriate relative to the glucose level. As well as an ineffective counter-regulatory response to the dropping glucose levels, we think might play a role, but that's still something that's being explored in these studies. Risk factors include sugar-sweetened beverages and the prolonged OGTT for 3 hours. And the prognosis, so far, the studies have not shown that there's an increased risk of progression to CFRD in patients that have postprandial reactive hypoglycemia. And hypoglycemia and OGTT and CGM has not been associated with hypoglycemia in free living conditions. There's a couple of recent studies by Kilberg et al. One was a 3-hour OGTT with adolescents and young adults who have pancreatic insufficiency with CF versus 15 historical healthy controls. And another was a mixed meal tolerance test on 34 pancreatic insufficient CF patients over 16 years of age. On the 3-hour OGTT, there were 65% of the CF patients and 55% of the controls that had a glucose under 65. And this study is important because it shows that even though hypoglycemia occurred in both groups, the pathophysiology was different. In the CF hypoglycemia group, there was a higher 1-hour glucose and lower overall nadir in the glucose level. There was lower insulin C-peptide and insulin secretory rate under the curve at 0 to 30 minutes, but a higher insulin C-peptide and insulin secretory rate area under the curve at 120 to 180 minutes. And then there was also lower change in glucagon and free fatty acids. So the authors here did see that there was a distinct difference in the CF group. And then in the mixed meal tolerance test, that was only in the CF patients with pancreatic insufficiency, and 26% of them had a glucose under 70, which you could argue is that significant or not, but that was what they used for the study. And the hypoglycemia group, it tended to occur at about 150 minutes into the study. And they had lower early phase insulin secretion, a higher peak glucose, and they had a high late insulin secretion that was inappropriate relative to the glucose level at that time. But in the incretins, there was lower GLP-1 but higher GIP, so it was inconsistent with the previous study. There was no difference in glucagon secretion. With iatrogenic hypoglycemia, mostly we think of the CFRD patients on glucose-lowering therapies. It can also occur with medications and iatrogenic adrenal insufficiency. There's only actually a few studies in the CFRD patients. With Turney reported 58% of patients had over 2 episodes of hypoglycemia in a 1-week diary. Grover reported that patients on glargine has 6 plus or minus 1 hypoglycemic event per subject, and then on NPH 5 plus or minus 1 hypoglycemic event. And in Dr. Moran's CFRD-T trial, that was a 1-year multi-center trial, so this was larger than the other ones, 16% of the CFRD patients on aspart prior to meals and 23% on repaglinide had non-severe hypoglycemic episodes versus none in the placebo group. So it was significant compared to the placebo group. And then we have one study in the inpatient setting done by Jones, which showed hypoglycemia in 6.3% of all measured capillary blood glucose measurements, not plasma. The risk factors for hypoglycemia in CFRD patients are overall similar to other diabetes patients, with the one caveat in the inpatient setting, they showed that there was a higher proportion of low glucose readings between midnight and 6 a.m. specifically in the CFRD population. And with the Jones study, it was important when the patients did have hypoglycemia during the inpatient admission. This was significantly associated with a significantly higher readmission rate and mortality over the subsequent 3.5 years. So we've talked a bit about CFTR modulator therapies, and this study was mentioned by Lena as well, the GAIN study. And there were actually patients that were on a combination of lumacaftor with ivacaftor or tezacaftor, or with ivacaftor and also ivacaftor alone. There were a total of 4 patients that completely went off of insulin and 1 patient that had much less insulin requirement. And even after going off of insulin or lowering the requirement, there was still episodes of hypoglycemia in 3 of the patients. 2 of them had gating mutations, and then 1 was homozygous for delta F508. With Trikafta, we don't really know, so hopefully more studies will show. But for the FDA prescribing instructions, it's reported on that label that the hypoglycemia frequency is somewhere between 2 to less than 5% and higher than placebo by greater than 1%. So prevention and treatment, for any patients having hypoglycemia, education is really important of symptoms prevention and treating it. 15 to 20 grams fast-acting carbs is what we usually tell them. And for reactive hypoglycemia, we educate the patients to have mixed meals, eat carbs every 2 to 3 hours, and to consume less refined sugars, especially sugar-sweetened beverages, but it's unclear whether low glycemic index diets help. With CFRD, It's same as other patients with diabetes. They have severe hypoglycemia, glucagon, IV dextrose, and then inpatient precautions based on American Diabetes Association standards of care is to monitor blood glucose levels before meals and bedtime. You can do up to 7 times a day, and for every 4 to 6 hours for MPO, and every 30 to 60 minutes on IV insulin drip, and to aim for glucose levels between 140 to 180. So the unanswered questions and future directions. Do highly effective CFTR modulators increase the risk of spontaneous and insulin-induced hypoglycemia in people with and without CFRD? We have to have more studies to answer that. What is the prevalence of hypoglycemia and impaired hypoglycemia awareness in CFRD patients on basal bolus insulin therapy? What are the risk factors for severe hypoglycemia in CF patients? And do insulin pumps, CGMs, closed loops help reduce the rates? And then what about the patients that don't have CFRD? Do CGMs have a role in preventing recurrent and or severe hypoglycemia? So that's it for my talk. And just wanted to acknowledge everyone who contributed, and thank you to the Attain Health Foundation.